I came back with another lecture. In this lecture, we will talk about graft versus host disease or GVHD. Graft versus host disease or GVHD is an immunologic syndrome or phenomena that manifests as sets of signs and symptoms. It is an inflammatory response resulting in organ damage primarily due to T-cell invasion. As we discussed in our previous lecture, T-cell is a specific type of white blood cell that belongs to the lymphoid family. In GVHD, T-cells in donor organs invade the recipient's organs. So when does graft versus host disease happen? It mainly occurs after a bone marrow transplant or a stem cell transplant, but it can manifest following transplantation of solid organs rich in lymphoid cells, such as the liver. Another setting that can result in graft versus host disease manifestation is after non-irradiated blood transfusions. Graft versus host disease is subdivided into two major categories, acute and chronic. This categorization of graft versus host disease used to be mainly based on presentation time. Definition gradually changed, and now it's categorized based on timing, underlying mechanism, and the number of the organs involved. Why? Because both acute and chronic subtypes can overlap and manifest earlier or later. Hence, the role of timing has become less significant. Current National Institute of Health consensus criteria uses clinical findings rather than the time of onset for classification of graft versus host disease. Based on NIH criteria, the graft versus host disease is subdivided into 4 subcategories. The first type is called classic acute graft versus host disease. This type occurs within 100 days of transplantation with classical clinical features of acute graft versus host disease, which we will discuss later in this lecture. The second type is called persistent, recurrent, or late onset acute graft versus host disease. The patient in this subtype presents with clinical feature of classic acute graft versus host disease, but after 100 days of transplantation. The third subtype is called classic chronic graft versus host disease. It presents after 100 days of transplant with classical clinical features of chronic graft versus host disease. And the fourth type, and the last one, is called overlap syndrome. It may occur at any time post-transplant. It has features of both acute and chronic graft versus host disease. Graft versus host disease is considered one of the leading causes of morbidity and mortality after hematopoietic stem cell transplantation. More than 10% of patients will die from this complication. Acute graft versus host disease can occur in up to 50% of patients receiving a stem cell transplantation from a human leukocyte antigen or HLA matched sibling. I need to mention that human leukocyte antigen or HLA are proteins that are located on the surface of the white blood cells and other tissues in our body. When two people share the same human leukocyte antigen, they are said to be matched, that is, their tissues are immunologically compatible with each other. In partially matched transplant recipients, post-transplant cyclophosphamide, the drug that we explained in our previous lecture, decreases the incidence of grade 3 to 4 acute graft versus host disease. The occurrence of graft versus host disease is typically higher in unmatched donor. And also the incidence of chronic graft versus host disease ranges from 6% to 80%. So how does graft versus host disease happen? Graft versus host disease has 3 different phases. Phase 1 is a little bit complicated phase that I need to provide some information before going into detail about this phase. We need to know that radiation or chemotherapy is expected before bone marrow transplantation. This is part of the process for preparation of the recipient organ to accept the donor's tissue. This preparation can also cause recipient tissue damage. In addition, the preparation process causes immunosuppression, and the recipient is more prone to getting infection. Infection in the recipient can also further activate donor immune cells, mainly lymphocytes. These factors lead to increased level of inflammatory molecules called inflammatory cytokines. On the other hand, tissue damage, such as damage to the gut, which I depicted on this image with the blue arrow, and the release of microbial contents result in activation of the cells that present foreign material or antigen to the T cells. These cells are called antigen-presenting cells or APC. In the phase 2, this phase is characterized by interaction of the donor T cells with host APC cells that proliferate and differentiate into activated T cells, which release additional inflammatory cytokines. Then the next phase happens, phase 3. In phase 3 is characterized by migrating different types of activated cells to the targeted organs, resulting in tissue damage and failure. These tissues are including liver, the skin, and gut. I also need to mention that mechanism of chronic graft versus host disease is a little bit different and more complicated. In chronic graft versus host disease, the recipient B cells and T cells become out of control. B cells start producing anti-host immunoglobulin and T cells induce chronic inflammation. Later, another type of recipient cells called macrophages and fibroblasts will also be activated, resulting in further damage. Let's continue with manifestation or clinical presentation. In acute graft versus host disease, we use two grading systems for measuring its severity. One of them is Glasberg grading system from 1 to 4, and the other one is the International Bone Marrow Transplant Registry or IBMTR grading system, which grades the severity from A to D. Acute graft versus host disease typically manifests after the first 25 to 28 days after transplantation. It most commonly involves organs that are the three largest organs in our body: skin, liver, and gut. The skin manifestation in acute graft versus host disease can be from a mild rash to overt skin sloughing. In the liver, it primarily affects specific anatomical structures called biliary ductiles and present with abnormal liver function, which can be depicted on lab workup. In gastrointestinal tract or GI, it can affect either upper GI or lower GI. In lower gastrointestinal or GI involvement, it typically presents with diarrhea and abdominal pain. However, in upper GI involvement, it usually presents as nausea and vomiting. Now let's talk about the manifestation of chronic graft versus host disease. Depending on the number of the affected organs and severity of the involvement in that organ, chronic graft versus host disease further subclassified into mild, moderate, and severe. In moderate form, 2 or fewer organs and no clinically significant organ impairment exist. In the moderate form, 3 or more organs with no clinically significant impairment or at least one organ site with clinically substantial functional impairment but no considerable disability exists. In the severe form, chronic graft versus host disease causes significant disability. Now let's talk about the most frequent affected organs in the setting of chronic graft versus host disease. The first organ is skin. Chronic graft versus host disease can present as rash, hardening of skin or scleroderma, inflammation of the fascia under the surface of the skin, and open sore. The next organ is salivary gland. chronic graft versus host disease can present with dry mouth. The next organ is liver. Chronic graft versus host disease can result in abnormal liver function that can be found in lab workup. The next organ is GI tract. Chronic graft versus host disease predominantly affects esophagus. It can also present with nausea, vomiting, and weight loss. The last organ is lung. Chronic graft versus host disease can damage tiny airways via inflammation, which result in extensive scarring and blocking the airways. This abnormality can be detected in pulmonary or lung function tests. Thank you for your attention.